Okay, hello everyone, and welcome to this session of the PoCUS collaboration. I'll be your host, Michael Trauer, an emergency physician from St. Thomas's in London, and my co-host tonight is the beautiful Gokul Bailur. Would you like to say hello as well, Gokul?
Hi, welcome everybody. It's going to be interesting.
Yeah, so we've got a nice short, sweet session for you tonight on renal PoCUS. So there was a long session on this topic last year, by Ash Matties and Carl Chopra, where they go through in full detail how to do a renal PoCUS scan. So if you'd like to check that out, it's on the same channel in the Slack group. But this session will just be a few interesting cases. So we won't go through exactly how to do a renal scan. So yeah, let's just leap straight in with a couple of questions. So I'll just share my screen. So first, if you grab your mobile phones and go to menti.com, MENTI.com, and then pop in this 8-digit code at the top of the screen. So 8, just a sec, 86330234. So yeah, go to menti.com, MENTI.com, and then 86330234. And the first question is just, how often do you use renal PoCUS? So I appreciate this is a pretty select group that we have here. So this may not be representative of the whole country, but just to give us an idea so we can pitch the session appropriately. Yeah, I mean, such a small group, I think I know most of you as well, and I know most of you do use it quite a bit. Jim Harris every day, cool. All right, and then the next question is, in what situations do you mostly use renal PoCUS for? So I think the most common 3 situations would be flank pain, AKI, and sepsis, but maybe there are other indications you use it for, or possibly combinations of these. So for this one, you can use the slider bars to drag within each of those indications. You can drag your frequency up from 0 to 10, and then Mentimeter will average it out across each of you. Yeah, let me know if any of you are having trouble logging in. Tim, all of the above, cool. Okay, so the most common indication seems to be flank pain, followed by sepsis, and then AKI. And would anyone like to comment on the other? What other indications do you use it for? Feel free just to unmute yourself and call out. Perhaps hematuria, I guess, could be another potential indication. Okay, let's jump over to the slides. So, case 1. So this was a real case, a young man I saw a few weeks ago. So 28-year-old male who had a background of learning disability. He presented with fever and rigors. Wasn't much other history available due to communication, and also he was quite unwell. But there were no real signs of a particular source of infection on exam. So his chest was clear, his abdomen was nice and soft, ENT was clear. In terms of his OBS, he was pretty febrile and a bit tachycardic with a moderately raised lactate. But yeah, there was no particular clue to where this infection was coming from. So I decided to augment my clinical exam with some point of care ultrasound. So I started with his left kidney. He wasn't really complaining of flank pain, just kind of all over body pain. This was the left kidney, and I hope you can all see that okay. I don't know if one of you would like to comment, perhaps Vasileos or Greg, just feel free to unmute yourself and call out what you think. So this is with the low frequency probe marker to the left of screen. So his head is to the left, feet to the right.
Looks like this image looks normal.
Good.
Yeah, the pelvis is bright white. Doesn't look dilated.
Yep. Yeah, great. So yeah, we have the spleen up here, just below that. You can see a little bit of diaphragm here, and then this is the kidney nestled in below the spleen. And as you said, you've just got this nice normal bright white sort of fatty sinus of the kidney with no real visible collecting system. So that's just normal. And then how about this one? This was the right side. Yeah, since we're such a small group, feel free just to pretend we're just in a room together. Just unmute yourself and call out what you think.
So this seems like a moderate to severe hydronephrosis. We see like the calyx dilated. Yeah.
Yep, fantastic. Yeah, absolutely right. And then here's a video clip of the same thing. So yeah, hydronephrosis is the main finding we're looking for with renal PoCUS. And it's often described as having the appearance of a bear's paw. So yeah, in this image, the palm or the heel of the bear's palm is like the pelvis. And then these nice big fat finger pads are like the calyces. So yeah, you can sort of grade hydronephrosis from mild to severe, but I think from an A&E perspective, yeah, mild hydronephrosis can sometimes just be because someone's got a very full bladder or if they're pregnant. So if you see some mild hydronephrosis, it's worth having the patient have a wee and then scanning them again, and it might just go away. But if you're seeing sort of moderate or severe hydronephrosis, if you see the calyces, then that is usually because there's a pathological issue like an obstruction. So if you just see a sort of prominent pelvis, that's not always necessarily something pathological. But if you see these big calyces, the finger pads of the bear's paw, then that's at least moderate hydronephrosis, and you know there's something going on. And this was the CT of the same patient. So on the left, normal, and on the right, we can see this is the renal pelvis. This is the proximal ureter here, pretty dilated, but no obvious stone or obstruction, or cause of the obstruction, sorry. And then this is the coronal view. So here's the dilated renal pelvis, but there's no sort of bright white stone sitting there causing the obstruction. So yeah, in this case, it was actually a ureteric stricture. So the patient was admitted under urology and had a stent placed later that day and did very well. Fever came down the next day, and I think he went home 24 hours later with oral antibiotics. So I think that case just sort of demonstrates that PoCUS can have a role in patients with fever without a clear focus of infection. So the learning points for me, yeah, identifying hydronephrosis is relatively simple, especially if it's sort of moderate to severe hydronephrosis. It's usually pretty obvious. Yeah, as a rule of thumb, if you can see calyces, then that's significant. There's an obstruction going on. If you just see sort of very mild pelvic dilation, that could be nothing. So consider just having them have a wee and scanning them again. And yeah, in patients with fever of an unclear source, consider looking at the kidneys and the gallbladder. So as you know, in the new RChem curriculum, shock is actually now part of our sort of basic scans that we should be able to do. And one common shock protocol is the RUSH or HIMAP protocol. So some of you may be familiar with this: H for heart, I for IVC, M for Morrison's pouch, A for aorta, and P for pneumothorax. But if you have a patient in septic shock, you may want to expand that slightly. So say you do a HIMAP and you don't really see any cause of shock. Maybe the heart's a bit hyperdynamic. Maybe there's a history of some fevers and you think, could this be septic shock? You can, rather than being trapped in a rigid box, you can feel free to step outside the box and expand your HIMAP into a HIMAP plus exam, where as well as looking for DVT, to look for massive PE, you could also look for sources of sepsis. And the main things here would be the kidney, the gallbladder, and the lungs. Yes, that was case one. Any questions or comments on that case before we move on?
Could I just ask, just out of experience, you said about patients who might have a full bladder, who have could have something that looks like mild hydronephrosis. How often do you see that resolve immediately after passing urine? And also, would you normally see it on both sides. So seeing it on one side, we might be higher suspicion of something maybe obstructive on that side.
Yeah, I think it should resolve pretty much straight away as soon as patient has a wee. And I guess, yeah, it should be bilateral if it's from bladder distension. But yeah, if it's only mild, even if it was just on one side, still worth having them just have a wee and seeing if it goes away. And yeah, I think if it's only mild, it may not be an actual pathological obstruction. It could just be sort of normal variant. But if you can see those calyces, then there's something going on, I would say. But any other comments from our distinguished guests?
There was a question about whether he had any loin pain, tenderness on abdominal exam.
Oh yeah. Yeah, he did. He was kind of tender all over. He was kind of rigoring, looked pretty unwell. So yeah, when we asked, do you have pain? He was kind of saying everywhere, not particularly in the loins. So I think, yeah, it wasn't sort of exquisitely tender on one side. And I think, yeah, in this case, it was a young person with learning difficulties, but I guess the more common situation would be an elderly patient with some cognitive impairment who also can't give a good history, where the examination findings may also be not very overt.
There's also a comment, studies suggest emergency physicians overcall hydronephrosis versus radiologists.
Okay, yeah. Yeah, I think definitely if it's only mild, there is a risk of overcalling it. So yeah, I think if you see the bare claw with the calyces, then that's going to be significant. That's what I tend to use as a threshold for definitely labeling it as hydro. Cool. Any other comments before we move on to the next case? Great. Okay, so case 2. So this is another young patient, this time a young lady who presented with left-sided flank pain. She'd had a renal biopsy a week ago. She was being worked up for renal disease of unclear cause. She was a little bit tachycardic, but her blood pressure and hemoglobin were both normal. So she was initially seen by one of the RAT registrars who felt her tummy was a bit tender, but yeah, wasn't particularly worried about any particular diagnosis, and so just gave some analgesia, and the plan was just see if it settles. Then I came to review her a bit later. The pain had settled, but she was still tender, so I decided just to do a scan. So this is the right upper quadrant. Would anyone like to just unmute yourself and comment on what you see here for this right upper quadrant view? So this is the liver here at the top. This is the right kidney here. And I don't know if this projects onto your screens, but can you see there's a tiny little rim of black fluid in between them? So obviously we would fan through this whole region, but just from that single image, there is a suggestion that there could be a tiny rim of free fluid there. And then this is the pelvis in a sagittal plane. So this is the urinary bladder here. These are some bowel loops. And then, yeah, this black or anechoic area here just on top of the bladder is free fluid. And we know it's free fluid because it's kind of spiky in its appearance, because it fills in all the little nooks and crannies in between these bowel loops. And here's just another view of some spiky black free fluid in the pelvis. And this is the left upper quadrant. Would anyone like to comment on what you can see here? So this is the spleen here, diaphragm here, it's the kidney somewhere here. Sarah, would you like to make a comment, or anyone? Just feel free to unmute yourself.
Again, yeah, it looks like there could be some fluid between the kidney and spleen.
Yeah, you mean just here, or
Are
we talking about it here?
I was talking about where you're pointing to now.
Yeah, I think this is actually within the renal capsule. This is the renal capsule here.
Okay.
And then this is a bit of free intraperitoneal free fluid here, and possibly a little bit here between the spleen and the diaphragm. So I think both within the renal capsule and also outside. Yeah, and how about this image? So this is actually in the left iliac fossa. Any comments on this image? You don't have to necessarily say what it is, but just you can describe what it looks like in sort of ultrasonographic terms.
How old was this patient, Michael?
Say that again, mate.
How old was she?
24, 1 week post renal biopsy. This is on the left. Biopsy was on the left side, pain's on the left side, and this is just below the left kidney in the left iliac fossa.
Okay, that looks like an inhomogeneous mass of different densities, suggestive of a possible bleed in this context.
Yeah, excellent. So yeah, it was indeed a bleed. She went for a CT, which contrast enhanced CT, which did show some active arterial bleeding, and so she then went on for a super selective embolization, which basically solved the problem, and she did very well. Went home a couple of days later. So yeah, learning points for this case for me were that bleeding can present, can be a bit delayed after a biopsy, so it can be 1 or 2 weeks later. And blood can be of different appearance depending sort of how acute the blood is. So, in trauma, when a patient's just been brought in by ambulance straight from a car accident, obviously we're looking for that black anechoic blood, and it will tend to be spiky because it fills in all the little nooks and crannies. But if it's a bit more subacute bleeding, then blood can actually become quite echogenic, can be sort of heterogeneous in appearance, as you were saying, Joe. So yeah, just to be aware of how blood can change appearance over time. Cool. Any questions or comments on that case? That was really more of an EFAST case, but.
Yeah, that was very interesting. So that suggested like active bleeding, isn't it?
Yeah, I think that
Intensity.
there was also that anechoic fluid. Yeah, it does suggest active bleeding as well as that big accumulated hematoma as well.
Was that subcapsular blood on the right side?
No, all on the left. Yeah.
Okay.
Cool. Great. So yeah, over to you, Gokul, I think for your...
And just only to ask, the only complaint was the left flank pain.
Yeah, she'd been fine for a couple of days post biopsy, and then pain had kind of gradually come on a few days later and sort of gradually worsened to the point that she finally called an ambulance. So I guess as the capsule was kind of stretching, that was causing the pain. Yeah, she never actually had syncope or dizziness. I guess because she was young, she was, even though she'd lost probably a couple of liters of blood into her tummy, she was actually kind of compensating quite well. And I think the initial tachycardia was attributed to maybe being just from her pain, but the tachycardia persisted and she was still quite tender. So yeah, I think we probably would have, to be honest, probably would have got a CT anyway for her. But I think, yeah, the scan just kind of expedited things. Like we knew exactly what was going on. We knew she was losing quite a lot of blood. So, we moved her around to resus, got like big cannulas in, got the IR happening as quickly as possible. Whereas, if we'd just kind of been doing a CT to rule it out, maybe things wouldn't have happened quite so quickly. So yeah, it wasn't like a huge game changer. It just kind of helped expedite things, and we knew exactly what was going on from the beginning. So if she had deteriorated, we could have really jumped on it.
Yeah, thank you.
Great. And I think Gokul has a very interesting case. Thank you, mate.
Thanks, Michael. Are you able to pin me just so that I can show my images as well?
Yeah, it's a bit rattly or metallic. Something's going on with your microphone. I can hear you, but it's like something's buzzing or something. Maybe unplug and plug.
Yeah, I can try that. Is it better?
Still just a bit metallic, but can hear you okay. So
Okay, let me just try.
Is everyone else getting that same sound?
Is it better now?
Yeah, no, it's better.
Okay, sorry about that. So for those who don't know me, I'm Gokul. I work as a A&E registrar at St. George's, and I'm also lucky to be the point of care ultrasound fellow. So I get some nice dedicated time to go around the department scanning. And during this period, I have gained a bit of experience with renal ultrasound. I started off using ultrasound for mainly EFAST, but we were looking at kidneys while doing EFAST, so I got more into using it for other renal related pathologies. So today I'm just going to discuss about 2 cases briefly where ultrasound played a very important role, expedited care, and also learning points in terms of pathologies I can see with an ultrasound, in especially renal PoCUS. So we'll just go through the first case. So this was a 60-year-old. There wasn't too long ago. It was a 60-year-old who came to the A&E basically for 2 days of right-sided lower abdominal pain, which is, she said, was very mild. And then just an hour before coming to A&E became 10 out of 10. She looked pale at the time. She was having nausea, had 1 episode of vomiting. Was seen by one of my colleagues. She had, on examination of note, right iliac fossa tenderness. She was guarding. And also they felt that there was a pulsatile mass in the abdomen. She's 60, so they were concerned about AAA as well. Her vitals were fairly okay. Heart rate was 90, blood pressure over 110/70. She's not on any beta blockers. And pain was about 6 out of 10 after cocodamol. A urine dip showed some trace blood, proteins, leukocytes, but nitrates was negative. So at this point, the pain is slightly better, but she still got pain, a little bit of a wide differential. Is it appendicitis? Is it pyelonephritis? Is it a calculi? Is it a AAA? Don't want to miss a AAA. So they asked me if you could do a quick AAA scan. So that's what we did. So this is the first image. So I'm looking at the aorta. And obviously, does anybody want to comment on the aorta? Anything abnormal or normal? So this
To me, yeah, looks normal.
Looks normal. Yeah, that's what the first view was. This is, I think this is called the Snowman Sign. But this is, you've got a normal aorta here, and you've got IVC, you've got your SMA, and you've got a left renal vein. So a normal scan, couldn't see any obvious dilatation. So went ahead and saw the aorta in the long axis as well. Can't see any abnormal pathology, but I can understand why they felt there was a pulsatile mass, because you can see the distance between the skin and the aorta. It's not that, she's a very skinny lady, so might have pressed a little bit deep. You can feel the aortic pulsations. So AAA is not the case. So why does she have right iliac fossa pain that's going down the back? And why was it 10 out of 10? So went ahead and did a right-sided Morrison's like EFAST kind of scan. So I'm mid-axillary line on the right side. And this is the first image I can see. Can anybody see a pathology or something that they're worried about? This image.
The pelvis looks dilated.
Yeah.
And the calyces are opened up, so maybe moderate sort of hydro. Is there a bit of free fluid in the pouch as well?
Yeah. Anything else? You're absolutely correct about the dilated pelvis. Looks like there's some dilatation of the pelvis there. There is a bit of free fluid just between the liver and the kidney. This triangle of free fluid there. You can also see some shadowing. I'm not sure if you're able to see it from the images here, but you can see a shadow there. You can see a shadow there. And it looks like that's coming from certain echogenic material within the kidneys. Then you've got this psoas muscle and the spine. So at this point, I'm like, there's some free fluid in the abdomen, and the kidney looks like there might be some hydronephrosis. So we kind of looked at the kidney properly. And here I can clearly see that the pelvis is dilated. There's hydronephrosis, the calyx are dilated, and there is some echogenic material within the kidney with some shadowing that I can see, and a bit of free fluid around the kidney in the Morrison's. this is another image where I've just thrown some color on that. Does anybody want to comment on what we see on this image? Just color on the, basically on the kidney.
Yeah, Jared, do you want to make a comment on that? You've just finished your physics paper for your PGC. You should be all over this.
Yeah, I mean that one look diagnosis. It looks like there's you can see blood flow. Can I see the image again, please?
Yeah, are you able to see the image?
Yeah, there it is. Is that Twinkle artifact on the upper
Yeah.
pole?
Yeah, perfect. So that's, you can see two kind of twinkle artifacts and comet tail artifacts that usually is coming down from the echogenic material, and you can see the posterior acoustic shadowing behind it. So twinkle artifacts suggest that these echogenic material might be stones. And also the color box kind of covers the part where I'm looking at the dilated pelvis and there's no flow there. So trying to rule out whether it's a blood vessel or it's just hydronephrosis that I'm seeing there. And go ahead and looking at the short axis of the kidneys. Again, I'm just fanning through. So it's a 2D image, but you want to see the whole kidney. So I'm fanning through to the upper pole here, and you can actually see the hydronephrosis, the dilated pelvis, dilated calyx, echogenic large material in the middle with the shadowing that might suggest a stone, and a bit of free fluid that I can see just there around the kidney. And looking at the other pole, so I'm just going down now towards the lower pole, and I see a lot of fluid and some stranding around the kidney. Can't really see the capsule well. And I'm now worried whether the pain is subsided because she's kind of burst, or there's some urinoma or inflammatory changes around the kidney. So we had a quick look at the blood test results, and the bloods were completely normal at this point. So normal kidney functioning, normal white cell response, normal neutrophils. CRP was normal as well. So looking at the bloods and initial presentation, but with PoCUS findings, we kind of had the diagnosis at this point. So this was probably out of hours. Getting a CT scan based on these, just on the blood and initial presentation would have been hard, knowing that the patient's getting better with the painkillers. But I think ultrasound kind of helped us expedite that, and we got a CT scan. And the CT scan showed 3 distal ureteric calculi, the largest being 6 millimeter. And there was another 5 millimeter and a 2 millimeter stones. There was hydronephrosis of the right kidney with what they suggested might be inflammatory changes around the right kidney and possible urinoma. We spoke to the urologist who came down and saw the patient as well, based on obviously the CT findings and PoCUS findings. She was admitted overnight for observation. Pain kind of kept getting worse. She started to spike temperatures. Was given antibiotics based on these findings earlier as well, but eventually needed to be taken for urgent ureteroscopy, and they did a ureterorenoscopy, which showed multiple calculi which were epithelialized. They didn't think they could get out the calculi, but they wanted to aspirate the hydronephrosis, the fluid, the urine. So they did that and put a stent later on, and eventually has been getting followed up for her nephrolithiasis. But during her stay, she did get a bit unwell, but slowly after the procedures kind of improved and had a good outcome. So I think ultrasound played an important role, especially 9 o'clock in the night. You're not able to get a CT scan. They might have said, okay, your pain is getting better. You don't have a AAA, maybe come back in the next day for a CT scan. So it's a possibility that she might have gotten worse. I think it kind of expedited the care and got her the proper treatment that she required at that time. So I just wanted to mention a little bit about Twinkle Artifacts. I never understood this concept before correctly. So why does this happen? I spent a few months as part of my PoCUS fellowship with sonographers. Everybody had a little bit of a theory as to why twinkle happens, but they all used it, and they said it's the best thing to find out small stones. They all loved to see some twinkle artifacts. They got all excited with the twinkle artifacts, but nobody gave me like a proper answer as to why it happens. Everybody had some theories. So a few theories that I've come across and I've read about is that possibly because of micro oscillations that happens on a rough surface like a stone, especially a calcium related stones. The other one is whether the ultrasound beam splits into multiple different beams, giving an impression of a turbulent flow. So turbulent flow causing aliasis and causing the twinkle disco kind of lights. And something related to ultrasound producing jitter and causing these artifacts. But whatever the reason, I think twinkle artifacts is a great tool to see small stones. Can be used for kidney stones, even ureteric stones. It's got a sensitivity and specificity of the twinkle artifacts is about 90%, 99% and 90% respectively for smaller stones as well, less than 5 mm, but can also be used for larger stones, like how we saw, which were quite obvious on the 2D image. Do you use twinkle artifacts a lot, Michael, on your daily practice?
No, I tend not to really. I tend to just go mostly by hydronephrosis. Like if someone's got a good history for stones, flank pain, hematuria, maybe a previous history of stones, and I see hydronephrosis, I tend not to really focus too much on trying to identify the actual stone. Like if you can see one in the proximal ureter, that's great, but obviously usually you don't see them, and the ones that are in the kidney are usually not causing a problem. So yeah, I tend not to spend a lot of time scanning through the kidney looking for intrarenal stones. But I think it's worth putting the color box on the bladder because, as well as the ureteric jets, which I tend not to actually worry about too much, but you can also, if there is a VUJ stone in the bladder, you'll often get a really nice twinkle artifact from that. And so then you know exactly, definitely that there is a stone in the VUJ, which is causing the problem. Yeah. How about anyone else in the audience?
Or anybody else has a question on this case?
So I have just a couple of slides I can quickly share just on the role of color Doppler in renal ultrasound, just to follow on from what you were saying there, Gokul. So great case, by the way. Thanks very much. So I think one reason to use color Doppler is if you're not sure if there's hydronephrosis or if it's just prominent vessels. And then, the other indications would be for the twinkle artifact and for the bladder jets or ureteric jets. So in this image, it looks like maybe there could be some hydronephrosis, right? There's this kind of prominent anechoic sort of tree-like structure coming up here. But if you want to just check whether that's hydronephrosis or prominent vessels, you can just throw a color Doppler box over it, and immediately you can see that that's just vessels. That's not hydro. So I actually use it for that reason sometimes. Often young patients will have these quite prominent vessels, and color can just help you determine that they are vessels and not hydronephrosis. I think it's also worth sometimes putting the box on the bladder, and as well as these jets, if there is a VUJ stone, you'll see that twinkle artifact coming down, and that's actually going to be a stone that's likely causing the problem rather than a stone that's sitting in the kidney that's probably not causing a problem.
Yeah, I agree. I think Professor Tim wanted to see the twinkle artifacts again of this patient. Yeah, there were two kind of comet tail artifacts behind the twinkle that you can see on this image, and also the shadowing there.
So I guess those stones that are causing the twinkle are probably not causing the problem, are they? But I guess it suggests the patient has lots of stones. So probably other stones that are actually further down the ureter that are actually causing the obstruction. I think the sonographers like twinkle because it can be hard to see echogenic stones in the kidney itself, because the surrounding tissue is already quite bright, like the fatty sinus is already echogenic, and so it can be quite difficult to see a very small stone within that So yeah, Twinkle can be great for picking up those little stones, but from an emergency medicine perspective, those are probably not so relevant to us if there are a couple of little intrarenal stones. So yeah, I tend to use Twinkle more for the VUJ stones. Cool. So for the last part of the session, I've just got a couple of discussion questions. So I'll just go back to Menti. So hopefully you're all still logged on. If not, just go to www.menti.com, MENTI, and then the same code 86330234. And I'm going to jump ahead to these last few little discussion questions here. So just imagine you're in this situation. So a 24-year-old female presents with flank pain. She's known to have renal calculi. Her examination is normal, tummy soft, bloods are all normal, renal function's normal, not pregnant, and her pain's actually now settled after some PR diclofenac. It's 9 a.m. on a Monday morning, so you can get any imaging you like. So what would you do? So I've given you 4 options. Just send her home without any imaging, do a point of care scan, do a formal ultrasound, or do a CT-KUB. Okay, so all of you going for a point of care ultrasound. Okay, let me give you one slightly different scenario then. So it's the same clinical situation, but now it's after hours. Well, I guess this is not going to change your decision because you're all going to do a point of care scan anyway. Yep. So then let's go to the final question, which is about access to CT-KUB. So I know those of you who work at Tommy's have 24-hour access to CT-KUB, but how about at other institutions? Okay, one place only for emergencies. Is that you, Gokul, or is that?
Yeah, that's actually me. Yeah.
Oh, really? Okay. St. George's, you only get them for emergencies out of hours, not routinely.
Not routinely. For trauma, we might, but for CT-KUB, we bring them the next day if we think they're well enough. But for emergencies, yeah.
Yep. Okay, interesting. So, yeah, perhaps would someone like to elaborate on the sort of thought process for how they're going to be using point of care ultrasound in this kind of situation with a patient where you're pretty sure it's a renal stone? There's no obvious signs of any complication. You think they're likely to go home. What role would PoCUS have in that situation? Feel free just to unmute yourself and. Jero, how would you use PoCUS in that situation?
I think in this situation, because you've got an exam that doesn't involve ionizing radiation, it's relatively easy to access and easy to perform. There's relatively to no downside to performing a point of care ultrasound in this patient in any case. It's not going to take you long, patient's going home. And if you do find hydronephrosis, it's an indication to discuss with urology rather than for routine follow-up. So a case like this for me indicates just the utility of ultrasound, and that's why I do a point of care ultrasound in a patient like this. Yeah, okay. I mean, I think any test we order in emergency medicine should only be done if it's going to change management. So yeah, it's good to think a bit about how our tests are potentially going to change management. Anyone else like to make a comment? Tim, would you like to comment on your practice in this situation?
He mentions that often discharge patients with suspected renal colic and no hydronephrosis with adequate pain control, no AAA, no other findings or infection.
Yep. Yeah, I think that's pretty reasonable. I mean, yeah, obviously most renal stones are going to be small distal stones that tend to pass by themselves without any intervention. Even if there is hydronephrosis, most of them will still pass, but obviously a bigger proportion of those stones that cause hydronephrosis will be the larger stones that do need some intervention. So it's all sort of statistics and probabilities, but if you have a patient who you're pretty sure has a stone and there's no hydronephrosis, you're even more confident that it's something that's going to pass by themselves. And so, yeah, in that situation, I think it's very reasonable to save them the ionizing radiation and just to let them go with some strict safety net advice. And even the patients who eventually get admitted to urology, often they'll just watch them for a few days anyway. They don't leap into doing something interventional. So I think as long as the patient's sensible and you tell them to come back if the pain persists, if it does turn out to be an obstructing stone that's not going to pass spontaneously, you haven't really lost much anyway. But I think if you use PoCUS to integrate with your pretest probability and make a sort of a judgment call that it's very likely to pass by itself, you can do some mutual decision making with the patient, and if they're happy to sort of monitor their symptoms at home, I think that's very reasonable. We probably could be discharging more patients without CT, so it's definitely something to consider. Some more comments from Tim. Too many patients for allocated CT time despite 4 CTs in the ED. Okay. Yeah, I think as well as the logistical issues, also just the cumulative radiation. I think even a CT KUB is at least a couple of millisieverts. And so if you have a patient who's a recurrent attender with renal colic, if you scan them every time, you're already significantly increasing their risks of cancer over their lifetime. And I guess you have to ask, what are you really doing it for? I guess you can tell them exactly how big the stone is and give them some slightly more specific information about how likely it is to pass. But I think, the main question really is it obstructing? Is there hydro? And we can pretty much just tell them that from a point of care scan.
I think its utility is also it's very useful in patients with undifferentiated cause for sepsis. Like you added it on to the high map, looking at the kidneys, looking at the gallbladders. I've seen that being very useful in certain group of patients who are not able to give you a good history and get the correct kind of modality of imaging for those, and then escalate their care as well.
Yep. Yeah. Great. Any questions or comments from anyone else? Feel free to turn your videos on if you like, as we get to the wrapping up stage of the session. Any questions or comments?
I just wanted to ask, it doesn't happen to me yet in the St. Thomas. If the threshold for doing a CT of kidney, ureter and bladder in this type of patients, we have flank pain, we have hematuria from the urine dip. We don't know how, we don't have access to someone that knows PoCUS. Is there any stratification like to who is at risk to order, or we are ordering like every patient with renal colic? From the conversation now, it doesn't seem to be that the case, but if we don't have access to point of care ultrasound, we don't have the experience, the expertise, or someone.
Renal PoCUS is not part of the standard sort of RChem curriculum. So there'll be lots of centers where there's nobody who is really skilled in it. So it is a bit ad hoc. It just depends sort of who's on shift, if there's someone who can provide that. But I guess it's only quite a narrow group of patients who will not be able to have a CT. So the very young patients, pediatric patients, pregnant women, obviously. And I guess in that group, if there's no one who can provide a point of care scan, but ultrasound is thought to be the best first line test, then I guess they would just come back, or either be admitted or come back, depending on how unwell they are, for a sort of formal departmental ultrasound scan during normal hours. Is that what you mean?
Yeah, it makes sense the way you. Yeah, basically my question was like during the day, if we scan every patient with this complaint, because I've heard about this happening often. It doesn't happen. It didn't happen to me yet. Having this type of patients, but just wondering how often and how easily we scan these patients.
Yeah, the vast majority of patients will just basically have a CT KUB because there's so few clinicians around in the UK who can do point of care renal scans. Hopefully in the future that changes, but the standard pathway is basically for a CT, unless you're either very young, pregnant, or you have recurrent stones, in which case you might try and get an ultrasound as first line. I think that varies a bit between different countries. I think like in the US and Canada, there'll be more It's more of a standardized thing to do a point of care scan as the initial imaging. But I think, yeah, in my experience in the UK, CT-KUB is now pretty much standard first-line imaging. And it's only really a minority of centers where they could even offer a point of care scan. Yeah, this is, I guess, part of what this group is about, is pushing the boundaries and trying to change practice. So
I guess the answer to that would also be just get scanning, and Renal PoCUS is all about that. And I feel Renal PoCUS is one of the parts of the kind of PoCUS where it's easy to get good at it quite fast. So the learning curve is quite fast. It's not very complicated. I don't know if that's the experience with everybody else.
yeah, I think so. Yeah, I think trying to identify hydronephrosis is not that complicated. Sometimes, yeah, it can be a bit subtle if it's sort of mild, moderate. Yeah, and there are a couple of traps, like we haven't gone into some of that stuff today about differentiating hydronephrosis from like peripelvic cysts or like a extrarenal pelvis. If you want to go through a full session on how to do renal PoCUS, check out that other session on the Slack group by Ash and Carl. Yeah, there are some traps, and it's definitely, you do need a period of supervision. But having said that, I think compared to a lot of other point of care ultrasound, it's relatively easy. If you're just looking for that binary question, is there hydronephrosis or not? I think that's very achievable by any ED clinician with a bit of sort of mentorship and supervision. Great. Any other questions or comments from the group? Sarah, Chero, Tim, Vasilios?
Michael, could I just ask about, in the absence of obstruction, we sort of really talked mostly about that binary question of, is there evidence of obstruction? In the context of pyelo, are the PoCUS findings easy enough to identify? Or we haven't really spoken much about other findings.
Yeah, the ultrasound findings in pyelonephritis. Ultrasound is definitely not a sensitive test for pyelonephritis, so definitely would not rule it out based on PoCUS. And the findings can be quite variable as well. Like you can get generalized increased echogenicity throughout the sort of renal parenchyma, but you can also get reduced echogenicity. If you see something really significant like an abscess or dirty gas within the kidney, obviously that's going to be very specific. But for most cases of fairly sort of mild, uncomplicated pyelonephritis, you may not see any changes. So yeah, I wouldn't use ultrasound as a specific tool to rule in or rule out pyelo. But if you think there could be an infected, obstructed urinary system, then obviously that's, I think, the main role I would use ultrasound for, is just to see if there is obstruction there. Is that what you're getting at?
Yeah, exactly. I'm just digging for other things to look for.
Yeah, I mean, definitely keep your eye out. Like with any organ, you get your long axis, you fan through, short axis fan through, and as well as hydro, you're looking out for stones, cysts, solid masses, and certainly if you see anything like that, definitely don't ignore it. But yeah, from most of the situations we're in ED, it'll be the presence or absence of hydro is going to be the main thing that is kind of the decision point for us. Cool. Any other questions or comments? Great. Well, we're right on 1 hour, so perfect timing. Thanks so much to you all for joining us. I'll post the recording on the Slack group shortly. We'll also post the details for the next session on the Slack group, so stay tuned and have a wonderful evening. Thank you, Gokul.
Thank you, everyone.
Thanks, guys. Take care.
Cheers, everyone. See ya.
Thanks a lot.